It's a pleasure to introduce our distinguished speaker, Dr. Sughra Raza. Dr. Sughra Raza is a professor of radiology at the Breast Imaging Division, and she's also Chief Division of Global Radiology at the University of Massachusetts Medical School. She's a fellow of the American College of Radiology and Society of Breast Imaging. She's born and raised in Pakistan, undergraduate at Medical College in Buffalo, New York, and Albany, New York. She has a professional career over 30 years as full-time clinical faculty at Harvard Medical School, from instructor to associate professor. Recently, she began working independently as a consultant breast imaging and radiology at BIDMC and Harvard Medical School. Her special interests are early detection of breast cancer and diagnosis, especially in limited resource regions of the world. Hope to expand on this work, and now that the pandemic is somewhat in control, most of this effort has been in Rwanda. Recently, she was appointed the editor-in-chief of the Journal of Global Radiology. This journal aims to provide an accessible platform for researchers around the world, focusing especially on radiologists in low-resource settings. Dr. Sughra will talk today about breast density. Thank you very much. Welcome, Sughra.
Assalamu alaikum. I'm Sughra Raza. I'm a breast imaging radiologist in Boston, where I have worked since 1991. And I'm very grateful, first of all, to Dr.Shaheen for inviting me to participate in this first annual International Multidisciplinary Breast Cancer Conference in Gaza. This is truly a very important milestone, and I'm thrilled to be part of it. I hope this will continue on an annual basis and bring better healthcare to the local community. We're going to talk right now about breast density and what it means for women everywhere, for us. There has been a lot of discussion about breast density in the last 10 to 15 years and what it means. It's almost a case of too much information. There's talk about breast density's correlation with cancer, studies suggesting that women don't know what density means. Women are wondering, do I have dense breasts? There's all sorts of public information campaigns about it, talking about any one of us could be dense. What does it mean? There's a little bit too much hype almost, where people are saying things like this: if you're among the 40% of women with dense tissues, there is danger lurking, almost double the risk of other people, all sorts of stuff, making it sound like density is your destiny. Literally, that's what this campaign ad says. Are you dense? Exposing the best secrets, and a lot of media hype. The percent of population that has dense tissues, what does it really mean? So I'm going to try to spend the next few minutes just explaining what density is and what it means and how we deal with it. I'm going to take us back to just talk briefly about what screening has done for breast cancer in primarily the Western world. Basically, from 1989 to 2012, breast cancer mortality was reduced by about 36 to 40% in the United States. There are long-term studies that show that this is primarily due to screening of the general population. What that means is that you're doing a test on all women over a certain age to look for breast cancer when they have no symptoms or signs of it. This kind of screening for occult cancer leads to early detection, earlier than it would be detected once it becomes symptomatic. And early detection has a direct correlation with better treatment options and better prognosis. Mammography is an image of the breast taken with an X-ray in a certain way. What we see on a mammogram is the tissues that the breast is made up of, which is primarily fat, glandular tissue, and fibrous supportive tissue. The proportion of each of these components varies with age, with hormonal influences, other exogenous chemical influences, and it's dynamic. It can change over time. It can change with the menstrual cycle in women who have many cysts or fibrocystic changes. Density, the word density, literally refers to the amount of white tissue on a mammogram. What this translates to for us as breast imagers or radiologists is that dense tissue can decrease the sensitivity of a mammogram. And this is because masses, whether they're benign or malignant, also are dense. And if you have a lot of dense tissue, masses can become hidden or obscured by the dense tissue. So sensitivity of mammography decreases with increasing density. I want to make sure that we all understand that density does not refer to how the breasts feel. If they feel heavy or thick, that doesn't equal dense tissues. Lumpy, bumpy breasts or nodular feeling breasts are not necessarily dense. They can be fatty. Sometimes even women with many small cysts can have fatty breasts or less dense breasts. Fibrocystic breasts don't necessarily have to be dense. So none of those four things necessarily mean dense tissues. Density is literally the amount of fibroglandular versus fatty tissue. Fatty tissue on a mammogram is radiolucent, which means gray or black, darker, whereas fibroglandular tissue is white, and white is what can hide a mass. We talk about density based on the BI-RADS density categories. BI-RADS is the Breast Imaging Reporting and Data System. It provides a standardized and uniform way of both evaluating and describing what we see on a mammogram. The density categories are A through D, A being almost entirely fatty tissues, B is scattered fibroglandular tissues, C is heterogeneously dense tissues, and D is extremely dense tissues. And I'm going to show you examples. This, as I'm sure you have guessed, is almost entirely fatty or category A, the two MLO and CC views showing you that. This mammogram shows an example of scattered fibroglandular tissues. This one is heterogeneously dense tissues, and this is extremely dense tissues. Now, of course, there's variability in the appearance of tissues on mammography. For example, this one is also extremely dense tissues, but much whiter than the last one. Here are three different patients' mammograms showing a different appearance of what I would call extremely dense tissues in each case. And what I'm also showing you here is that the complexity and texture of the tissues can be extremely variable from person to person. On the right-hand most image, as you're looking at the screen, you'll notice that I've hidden. Do you see that little mass that I superimposed electronically on that mammogram? And just to demonstrate how a mass can be obscured by surrounding dense tissues, you wouldn't really notice that unless I pointed it out to you. So density is important because of these reasons. This one particular reason that I just demonstrated decreases the sensitivity of mammography because that mass was obscured by the surrounding tissue. Mammographic sensitivity is about 87% in almost entirely fatty breasts, but only 63% in extremely dense breasts. So the two extremes are like 25% different in sensitivity. This phenomena is called masking, where surrounding tissue hides a cancer. Here's an example of masking. On the left hand is a patient with almost entirely fatty tissues, but the triangle marker over here is a sticker placed on the breast where the patient feels a lump. And you can see that there is an underlying mass, a dense oval mass with partially circumscribed margins. If this mass was present in a mammogram with dense tissues, like the image on the right, you can see I have taken electronically just that mass and placed it on the dense mammogram. And you can see how hard it is to actually visualize that. I put the asterisk on there for you so you could see it, so I could find it. But this is exactly what happens. Another way to look at it is use this illustration borrowed from my wonderful old colleague and friend, Dr. Robin Birdwell. Take a look at this pixelated little symbol, for lack of a better word. Notice that it is symmetric. Now I want you to look for this here. I'm sure you can. I can too, but it takes a little bit of time to go through each one and figure out where we see it. And you can see that these three represent the symbol we're looking for. The other pixelated boxes or squares are not the right thing. Now try looking for it. Let's say this is scattered fibroglandular tissue, and this is extremely dense. And now if you try to find that thing, there are 5 of them in this sea of similar pixelated pattern, and here they are. It just becomes much harder. and sometimes impossible. This mammogram was done on a 66-year-old woman who came in just for her screening mammogram, no symptoms. It was read as negative. You can see she has fairly dense tissues. She came back 3 weeks later saying she had a palpable lump. And because she just had a mammogram that was read as negative, we went straight to ultrasound and found this rather large, irregular, hypoechoic, suspicious mass, which turned out to be a cancer, of course. But in looking back at the mammogram, where this was palpable was this region pointed out by the arrow, and you can see that there's dense tissue there, but no discrete mass. So the second most important thing about density is that there is a demonstrated clear association of dense tissue and a higher risk of breast cancer. Density is considered an independent risk factor for developing breast cancer at some point in that woman's life. But I want you to remember that the difference here is in the two extreme density categories. Women with very high breast density or extremely dense tissue have a 4 to 6-fold increased risk of breast cancer compared to women with the least dense breasts. So the category A on the left hand and category D on the very far right hand, marked by the double asterisks, that's the difference we're talking about. And then it's gradual in between. So what is the distribution of dense tissues in our population? In the US, it's basically 10, 40, 40, and 10% in the 4 categories. So what that amounts to is that if you divide them in a binary fashion, the non-dense categories A and B and the dense categories of C and D, about 50% or half the population of women in the US have dense breasts. So what it means for us women is that if we have dense tissues, we have a 1.2 to 2.1 times the risk of someone with non-dense tissues, as long as that's the only risk factor we have. Density legislation was passed in the US in 2009 in the state of Connecticut only, where it was made mandatory that women should be informed by the radiologist if they have dense breast tissues. At this point, 38 and maybe more states have similar legislation. There are variable specific requirements that we don't need to talk about, whether the women just need to be informed or a consultation has to be offered or supplemental screening methods have to be offered. We'll talk a little bit about the supplemental screening in a bit. Just to go over a little more detail about this, there have been more than 40 studies now showing that density increases the risk of breast cancer in women of Northern European descent. So this is Caucasian women primarily. This data has not been validated in other racial and ethnic groups in whom density may be a poor predictor of risk. For example, African-American women in the United States are at highest risk, but they're less likely to have dense tissues. Also, breast cancer in African-American women tend to be more aggressive types, while those in women of European descent are the more often good kind of slow-growing cancers, the garden variety hormone-positive cancers. So even though there isn't really evidence-based guidelines about management of women with dense tissue, supplemental screening is being offered to many women in the US. This is done often with whole breast ultrasound and sometimes using screening MRI, but insurance companies will only cover the cost of MR if that woman's risk is 20% or higher for developing breast cancer in her lifetime. So most women who are offered and get supplemental screening it is through ultrasound. How do we radiologists determine density? Primarily, it's visual estimation. Quantitative assessment is the other method, which is not in as wide use yet. The visual method has been shown through many studies at this point to suffer from both intra and inter-observer variability. There have been recent changes in the guidelines from BIRADS as to categorization of dense versus non-dense tissues. So that also has not really helped with the inter-observer variability. Quantitative methods are complex algorithms based on area density or volume of dense tissues. Neither visual nor the quantitative method is perfect, although the newer AI-based or artificial intelligence-based density assessment tools using deep learning are much better at more consistent density assessment, but they're not in wide use as yet. Okay, so you've been told you have dense tissues, now what? It's important to remember, first of all, that there is variability in the assessment, especially if you're borderline between category 2 and 3, that can tip you. And because it's such a subjective assessment done visually by a radiologist, I may call something category 2 and my colleague calls it category 3, and it has pretty serious implications for that patient. So remember that this is not a hard science. Density does raise your risk, but only slightly. Other factors must be taken into account, and it's best to discuss with your physicians where exactly you fall. Family history is really important. Gene mutations, if there's a family history of it, you are familiar with some of these genetic mutations that we're learning more and more of. BRCA genes, P53 early Frommeni syndrome, CHEK2, ATM, PALB2, etc. Radiation exposure, especially if there was mantle radiation under the age of 30, raises your risk for breast cancer. Risk lesions found on breast biopsy, such as atypical ductal hyperplasia or lobular carcinoma in situ, also, of course, raise your risk. Personal history of breast cancer definitely does as well, but remember that most de novo breast cancers occur in women with no risk factors at all. So going on to supplemental screening options, basically there's very limited published data regarding any of these methods. There have been multi-center studies, an Akron trial of whole breast ultrasound, but many of those women didn't have only density as their risk factor. So you have to take all of that data with a grain of salt and look at the details. The common imaging modalities we have are ultrasound, MRI, and now increasingly contrast-enhanced mammography. So to talk a little bit about whole breast ultrasound, it can be either handheld or automated. Cancer detection rate is 2.5 to 5.3 per thousand, which is a little more than mammography. The biopsy recommendation is 4 to 5%, which is higher than the 1 to 2% for screening mammography. And unfortunately, the ultrasound positive biopsy rate is only 9 to 12% as compared to 30 to 35% for mammography. So we're biopsying too many benign things found on whole breast screening ultrasound. The handheld is, of course, operator dependent and very labor intensive. The automated raises questions about whether you are getting full coverage. It has a higher callback rate, and we don't have enough data about automated whole breast ultrasound outcomes. Breast MRI is a wonderful modality. It's much more sensitive than both mammography and ultrasound. The cancer detection rate is much higher, 10 to 15% per thousand. It can detect cancers that are not seen on any of the other modalities. And it's not affected by the amount of dense tissue or fibrograndular tissue. The positive biopsy rate is very respectable, 20 to 40%. The negative predictive value is close to 100%, which is great. However, MRI cannot be used widely because of its expense, accessibility. Some patients don't tolerate the MRI, and it also does have false positives, much higher than mammography, actually, because benign tissue also enhances, obviously. Here's an example of a 41-year-old who presented with a palpable left breast area of lumps. It wasn't just a single lump. It was in the upper mid breast. This BB marker on the MLO and CC view identifies the site of concern roughly, but it was like a bag of marbles in the upper mid breast. And the mammogram showed absolutely nothing discrete that we could put our finger on. And it didn't look different in comparison to a mammogram the year before. So we sent her to MR and look at the extent of abnormal enhancement in that left breast, which was occult on mammography. So just to demonstrate how MRI can be amazing. Other screening options that are becoming more used around the world, basically, some are more established and others are still under investigation. Molecular breast imaging is definitely being used in a number of places, and I'll talk a little bit more about that. Contrast-enhanced mammography, positron emission mammography, optical imaging, optoacoustics, And then blood tests or liquid biopsy hopefully will become more useful. It's not right now, it's still investigative. Molecular breast imaging, I'll just mention very briefly because it is radioactive isotope based. It has high sensitivity and a great cancer detection rate. The positive biopsy rate is also quite acceptable at 28%, but the radiation dose is still a bit too high. It's about 4 to 5 times that of mammography. And we don't yet have a way to biopsy a finding seen only on breast-specific gamma imaging, which is one of the methods of molecular breast imaging. Contrast-enhanced digital mammography, on the other hand, is more useful, I think. IV contrast is injected, the same, like Omnipaque, standard iodine-based contrast, and the mammogram is done with mild compression, tube use per breast as usual. The sensitivity is 86%, which is great, better than mammography, and accuracy is very high. In fact, some people call contrast-enhanced digital mammography a poor man's MRI because it is based on the same principle of enhancement of abnormal tissue. The cons are that it is IV contrast and we have to worry about contrast allergies, and there still isn't an easy method to biopsy findings seen only on this method, unless we go to MR then. But still, it is not a bad way to screen. So in summary, I want us to remember that density alone increases your risk only slightly, even though we talk a lot about it. The masking effect is equally important, and that's where we must remember as radiologists to look harder, to use whatever methods we have. If you have tomosynthesis, that definitely helps read mammograms of women with dense tissues. And also with not such terribly dense tissues. I have seen many examples of women with scattered fibroglandular density where the tomosynthesis shows subtle areas of architectural distortion not seen on the 2D mammogram. So if you have the ability to do tomosynthesis, that's definitely helpful. I know I didn't talk about it too much here, but it's such a given now where we work that we don't think about mentioning it. Anyway, it is important if you have dense tissues to refer your patients back to their physicians and have them at least have a discussion about what it means for them. And if they have other risk factors like family history, doing a proper risk assessment will be probably quite helpful. And then they can decide whether supplemental screening would be something they need to pursue or not. The most common methods of supplemental screening, again, are ultrasound and MRI. Contrast-enhanced mammography is becoming more widely used and maybe a good tool, especially in places where MR is definitely not easily accessible and not commonly available to patients. So contrast-enhanced mammo, which basically uses your standard mammography machine, and the imaging can be done fairly easily as long as the patient doesn't have contrast allergies. That's all I have to say about density. Here are some resources, and I thank you very much for your attention.